Welcome, everybody. We are going to get started right on time. We are so excited to present the OB-GYN Power Hour in our webinar series. Peter and I are delighted to welcome you from the butterfly end. We have gathered together this very diverse and excellent powerhouse of clinicians who use POCUS in their practice to speak about their tips and tricks, where they see value in POCUS in their pockets or nearby the bedside of the patients, and where the future of POCUS is going. So our goal at Butterfly is to put the power of ultrasound into the hands of clinicians who are actually caring for patients at the bedside to help them make rapid decisions about their patients to do better medical care. And that is what makes imaging ubiquitous, and it puts us on a path towards improving the quality of maternal health care for all. I'll start out by saying, currently 2/3 of the globe doesn't have access to a medical imaging at the bedside. With handheld POCUS, the access to ultrasound suddenly becomes affordable and easily deployable and highly accessible. We know that in 2022, the WHO revised its guidelines to put out an advisory policy that supports antenatal ultrasound scanning in all pregnant women around the world prior to 24 weeks, with the goal of identifying high-risk conditions. They call out point-of-care ultrasound as a screening tool that's synergistic or complementary to a sonography-performed full fetal scan, and why having both of these options together is ideal. Even in the US, many areas are considered obstetric deserts. Many rural areas where L&Ds are closing and patients have to travel really far to get antenatal care or to have a delivery in a hospital. So we have really unfortunate disparities in the US with outcomes that are linked to race and socioeconomic status of mothers, even here. And so conversations like these help us get thinking about better ways we can deliver care and learn from each other. So without further delay, I'd like to introduce our participants in our webinar. And I'm going to have them introduce themselves. And I'd like to start with Oniche Eke, Doctor.
Hi, everyone. Good evening. My name is Onyechi Eke. I am an ER physician by training. I'm also the director of Global Ultrasound in the Department of Emergency Medicine at Massachusetts General Hospital. It's an honor to be here with you all. My interest is how we can integrate point-of-care ultrasound practice into what we do in the ER every day. So I'm very interested in point-of-care training and education. So I hope that everybody has a good evening. Thank you.
Thanks so much. And over to you, Cecilia.
Hi, everyone. Thank you for joining. I'm Cecilia Leggett. I'm a current maternal-fetal medicine fellow at Stanford, previously trained in Los Angeles at Cedars-Sinai in OB-GYN. My area of focus for research is in integration of new technology into practice. And so a lot of my research has focused on how do you integrate things like the butterfly or handheld ultrasounds into practice and into your workflow in a way that's meaningful. And I've done research in that area to really work on quick integration and ease of use.
Thanks so much. We're excited to hear more. And over to you, Elizabeth.
Hi, good evening. My name is Elizabeth Stringer. I am a maternal-fetal medicine physician at UNC Chapel Hill. And my area of research is really in global health. I have a particular love for Zambia, where I lived for 11 years before relocating to UNC. And we've been involved in AI-assisted ultrasound, specifically for gestational age determination, but also with a host of other things. And so that's what I'll talk a little bit about later. Thanks for joining.
Excellent. And finally, over to you, Carrie.
Good evening, everyone. My name is Carrie Wheeling. I am the family nurse practitioner with Healthy Mothers, Healthy Babies Coalition of Hawaii. And I am here tonight really representing the integration of that point of care in a true community setting and being able to share with you folks how we utilize butterfly bedside in a mobile clinic.
I love it. Excellent. Well, we are very excited to get started. We will be taking questions, so feel free to pop them into the webinar, and we can see where we can work them in. And we do have a few prepared questions to kind of get our panelists started. So we're going to start out talking about emergencies. So for OB-GYN emergencies, how do you all consider the use of pocket-based ultrasound or handheld ultrasound in your different arenas? And I'm sure with each of you being in practice for as long as you have and being experts in point-of-care ultrasound, that you've each had clinical scenarios where you felt like having the probe really helped you to take good care of a patient that might otherwise have had to wait, or might have had a bad outcome if you didn't have that answer right away in your hands. And so anyone feel free to go first. But let's hear what you think about that.
I can go first. Oh,
Perfect. Dr. Ike, go for it.
no, I was just saying, as an emergency medicine clinician, of course, we are concerned about emergencies. So, having the accessibility of, point-of-care ultrasound, particularly a handheld ultrasound probe, allows us to evaluate pregnant patients when they come in for emergencies like trauma. So we will use it to do our fast examinations. When there's a concern for shock or hypotension, those are the major things. And of course, when there's a concern for a ruptured ectopic a pregnancy. So those are, I think, the top 3 to 4 things that we use it for.
I would say from the OB-GYN perspective, there are a couple emergencies that I rely on the handheld ultrasound for predominantly. So, one scenario is a lot of times when we're monitoring a fetal heart rate and we have decelerations, there are times when we have to emergently go to an operating room to potentially deliver. And the question is always, when we get to the operating room, if the heart rate is still down, we'll proceed with C-section. And if it's up, then we pause and reassess. And one issue that I used to run into is inability to find the baby on the fetal heart rate monitor in the operating room. And if you can't find the baby, then someone calling for an ultrasound and the time it takes to get that ultrasound, when the whole purpose of an emergent C-section is to get the baby delivered as soon as possible. So when you have access to the probe, in terms of finding the heart rate, you get to cheat, you get to look and identify. First, you can see the heart rate, but you could also identify exactly where to put the monitor. So that way you have the whole room can hear the heartbeat and kind of get a sense of which direction we're heading into. And so that's an obstetric specific use. But another thing we've been doing is in post-operative emergencies. So when you have concern for bleeding after C-section, taking a patient back to the operating room for a second surgery is a really big decision. Also, sending a patient for imaging, like sending a patient off your floor, is a big decision as well. And so when you have a handheld ultrasound, it's really easy to do a fast exam and see if there's free fluid in the abdomen to help, just as an extra data point. It's never the end all be all, but it's an extra data point that helps you make your clinical decisions. So I think those are 2 examples of everyday use, really, for someone to have this type of probe in a labor and delivery setting.
Yeah, one thing I'm curious about as you use both handhelds and card is your drastic difference in terms of what you're getting for information between the 2. In other words, do you, as you have the handheld and are doing these assessments, is there what's the difference, in other words, of when you would say, well, I need to use a cart-based system or not, or for general emergent assessment, are they essentially equivalent, or maybe the handheld is less than equivalent in that it's faster? I wonder what your feedback or their experience is with that.
So let me be transparent in that I have some bias because I did a validation study showing that you can use a butterfly probe for most obstetric indications. So that's my disclosure. I will say that I do think it's a valid tool to use in obstetric practice. And there are some instances though, in which I prefer a cart-based machine or need a cart-based machine. So one is logistics. If, I keep my ultrasound in my pocket. So if I'm in a hemorrhage situation, I'd rather not use something that I keep in my pocket, just in terms of cleanliness. And the other scenario really is, if something looks off or weird, I'll grab the cart-based machine because that's what my eyes trained with. It's what I know most. And I will say there have been scenarios where I had a face presentation that I saw with the handheld ultrasound, and those don't come in every day into labor and delivery, and so it looked a little bit off when I was scanning for presentation, and so I grabbed my cart-based machine, which is what I'm fluent in, if you will, and confirmed it. So those are kind of the two scenarios that come to my mind. I don't know if anyone has other experiences.
It's interesting to think about the screen and refer is almost, happening simultaneously, right? With the same provider and the same patient, but like as a quick screening tool where you can get your answers fast. And if something is amiss, kind of thinking about a more comprehensive scan, less mobile equipment. Elizabeth or Carrie, did you want to comment?
I mean, I think I'd just like to add that there are other benefits to POCUS, especially when you're taking care of really high risk women like we do I know you do at Stanford and UNC, like women with preeclampsia who may develop pulmonary edema. So, having that capability to diagnose that at the bedside is, I think, the wave of the future, and being able to do maternal echoes, right in the operating room on the labor ward. So I think that there are some other utilities to POCUS as well.
And just to add, in resource limited settings, sometimes there's no card-based system. It's either too expensive, it's broken, or it's not available. So the handheld or the POCUS machine is what you have. So it's going to be what you are going to use. I think that's the biggest advantage in areas where there's just limited resources.
And the cost, right? So if one breaks, it can be replaced. Whereas, if a huge, machine breaks, you can't really replace it. And so I think that's a huge benefit, especially in LMICs as well.
Yeah, and Carrie, tell us a little bit more about the mobile clinic and like kind of the space constraints. And I mean, it seems like the ideal place for
Yes, it is. I was going to chime in. So just to give background, Healthy Mothers, Healthy Babies is a nonprofit that our physical location, the main office, is housed in Honolulu, Hawaii. And the organization has been around for 30 some years, but most recently in 2020, we developed a medical arm to pivot to help bring in income to the nonprofit. And part of that medical arm, myself as a family nurse practitioner, offer family care, but it allows me to do prenatal, postpartum, newborn care. But I also have a midwifery. I have a group of midwives, certified professional midwives, who work with me, who also provide prenatal care. And one of the ways that we do this is in the home or via our medical mobile units, which we have on Oahu, on the Big Island, and we will have soon on Maui. So we have 3 offices that span the islands to help provide point of care to women. And we don't necessarily use it in an emergency setting, but we do use it when we collaborate with maternal-fetal medicine on high-risk pregnancies. It's often we run into women who have had no prenatal care or late prenatal care, and they have been referred and they need follow-up. They have no transportation. They are houseless. There's a variety of situations that we run into where it has been extremely beneficial to have the butterfly on hand. One, when we catch women who have had late or no prenatal care, their anxiety is really, really high. They don't know, is the baby okay? And I tell you, being able to get a look at the baby is phenomenal. These women, that it could be sometimes it's the first time they've seen their baby, and to see and witness a heartbeat live and something that you can take a picture of and snap and give to the moms, it reduces their anxiety significantly. And we're able to, do the ultrasounds in a way where we provide that to the moms, but we can also provide that to the providers that we're collaborating with. Sometimes the MFMs will send us out and say, hey, we just need to do a check on this mom for any number of reasons, but we want to know that they're doing okay. And part of it will be using the ultrasound so that we can see, yes, they're doing okay. We still have a viable pregnancy. We've been able to see the baby. We can see the heartbeat. We can hear the heartbeat. And all of those things are so important when we're working with moms. And it just brings tears to their eyes to be able to see the baby. And they'll bring the partner in the medical mobile van. And it's just a shared experience. And it's a fun shared experience. And that's the important thing, because sometimes in this work, you don't always get a fun shared experience. And that's what being able to provide ultrasound to families of Hawaii really brings us. And also to establish a pregnancy. Women will come into the office, they're not sure they're pregnant, they're not sure what they want to do with the pregnancy, but that's also or the timing, because they don't know when they got pregnant. So we can help give them a little bit of guidance as to where we're at in the pregnancy. Do we see a heartbeat? Do we not see a heartbeat? So this is where we think we're at. And, when they're trying to discuss their options, what do they want to do in their pregnancy? So it really provides us with a lot of power to educate the patients and to help guide them for whatever their next thoughts are in their pregnancy.
I'm assuming that sometimes it's not always good news, but how is that impacted when you assess women in your mobile unit and there's different decisions to be made? Is that something which has been happening with, getting the information to make a different decision? How does that work for you?
Absolutely. Well, we talk about reproductive health care, and you have to have full scope of reproductive health care. And some women, they're not sure that they want to be pregnant. So it's really verifying that, yes, in fact, you are. So what are you thinking now? Do you want to be pregnant? And you can sit down, and it's an intimate environment. When people come into our medical mobile clinics, they feel they're in a comfortable environment, they're in a trusting environment, and we take the time. So we spend often at least an hour with our clients, talking to them, being able to visualize the baby, really understanding the social aspects, because Healthy Mothers, Healthy Babies offers a whole slew of social services. That's what we do. We wrap our mothers in social and medical when we capture them into our care. So we educate them on what we have to offer: lactation services, doula services, medical services, safe sleep education. And it just gives us an opportunity. We say in Hawaii, talk story. It's just a way to get to know people. And I think it allows us to do that very eloquently and in a very safe and trusting environment.
That sounds so delicious, to have an hour with your patient to talk to them. I'm like, maybe I should have had a midwife for my babies, but that is amazing. And I feel like it brings up a good point of how the patients experience the time when they can actually see the picture, if things are reassuring, and also how the patients experience the time when they're waiting for an ultrasound and they're worried about something, and that wait, if they come in with vaginal bleeding, or they know that something's not quite right, but that wait for an ultrasound can be feel like a really long time across the board. And so there's real value in being able to answer those questions either way, right at the bedside. So we've talked a little bit about midwives in the US, and I wanted to kind of speak a little bit more about midwives and healthcare providers doing prenatal care in places like Zambia, or where Onyi has worked around the world. And so I didn't know, Elizabeth, if you wanted to kind of start us off talking about where you see the value of of POCUS in those settings where, there might not be the cart, right?
Sure, and I can talk a little bit about that. I was in Zambia a few weeks ago, and we have an implementation project to scale up Butterfly with the AI tool that I'm going to show a video in just a little bit. But I was training our team's midwives in how to use basic ultrasound with the Butterfly and identification of presentation, fetal heart rate, and they're then going to be training nurse midwives in the district clinics. And currently in the district clinics in Zambia, the midwives are using fetoscopes. So in many places, they don't even have a Doppler, right? And so I think that and a fetoscope can really, in expert hands, and I am not an expert at a fetoscope. The whole time I lived there, I tried. I just never could really become an expert in it.
Describe the fetoscope, because there's a lot of, I think, EM docs or family docs that maybe haven't practiced outside the US.
So a fetoscope, it almost looks like it's like two small cups, but they're made of metal, and you put your ear to one side and then the other side goes on the maternal abdomen, and then you can hear the fetal heart rate that way. But it really can only be used maybe after 28 weeks. And so when women are presenting to prenatal care earlier than that, a heart rate is not determined. And so you could do that with a Doppler, or you can do it with a handheld ultrasound. And so I think that that's one, just determining fetal viability is really, really important. And I was training the midwives with whom I'm working for about a week, and the learning curve was incredibly steep. Like, they were able to pick it up very, very quickly. Although when we talk about the next step of ultrasound and determining gestational age, learning how to do biometry is much harder to train someone on, right? And I think scaling up a whole force of midwives in Zambia, that would take a lot of time, right? And then there's turnover. And so I don't want to jump ahead, but later, using AI can help kind of springboard ahead some things that would take really long time to train.
Yeah, absolutely. Oh, go ahead, Anya.
No, I'm just saying, I was just going to add, so most of my experience has been in sub-Saharan Africa, and that's where I am from. That's where I was also born. So I think at least in some countries in the region, if you want diagnostic imaging, you have to pay for it first, and sometimes it's cost prohibitive. So one of the advantages of handheld and point-of-care ultrasound is that it is cheap, and because it is at the bedside. So patients don't have to pay out of pocket, but the clinicians can use the data from the images to make decisions. The second thing is that there's not availability. So even, let's say, if your diagnostic imaging is free, sometimes the ultrasound that is done by the radiology department, it could be a few times a week, a few times a month. It may not be available. The machine could be broken. So being able to train clinicians or have clinicians who have point-of-care ultrasound training, and then being able to use this handheld ultrasound, it just empowers them. It empowers them because now they don't have to wait for somebody else to maybe do this a study, and someone else to then do the interpretation. One clinician or one care provider can do both of those things. And I think that is the advantage. And really, that is the blessing of handheld ultrasounds, particularly in resource limited settings.
And I just want to add, I totally agree with you. And in many of the settings, a patient has to be referred for those things, and then they may or may not be able to go. And I really agree that it does empower the providers to be able to give that service. And then if there's a really high risk condition, observed, then they can refer to the appropriate place for the rest of the care.
Exactly.
Yeah, and certainly, as you mentioned, the fetoscope, that's really the evolution that when providers were practicing with the technology that exists before, it's essentially a stethoscope that has an abdominal bell. So the evolution of being able to do imaging versus trying to listen and interpret and see what you can do with those sounds has really been transformative, both from the stethoscope and for general assessment, but now also for women's health and the fetoscope, where people got really good at it, but the information that came from that relative to even being able to have an image and a handheld to make that decision, especially when it involves a decision about going someplace else for advanced imaging, has been really transformative.
Yeah, absolutely, Peter. Well, we're gonna shift gears a little bit. Dr. Leggett has done some really groundbreaking research on looking at what happens to time when you have a pocket probe in obstetric emergencies. And so, do you mind? I'm gonna share some slides to help the background here. And then Dr. Leggett, do you want to kick us off and talk about your pocket study?
Yeah, that would be great. You know, if you're attending this webinar, then you have at least some interest in learning about POCUS. And I think ultimately what we all want to know is whether this technology can change our clinical outcomes, our performance, our efficiency, and our ability to keep patients safe, especially in the ER setting and OB settings. So my partners and I did design the pocket study. We worked with experts in human factors to conduct a time and motion study on a busy labor and delivery unit to find out how access to, in this study, we actually did use the butterfly IQ, so how butterfly impacted our workflow. The primary outcome was clinical decision time. So we are looking at the time the decision is made that you need an ultrasound to the time that you make a decision. And so the first thing we did was create a process map by observing workflow. And so you can see that for personal device-based POCUS or handheld ultrasounds or pocket probes, whatever you want to call them, the process is very linear. So in the top row, you see a pretty streamlined process. You decide to perform an ultrasound, you have the device in your possession, you perform your scan, you make a decision. When you rely on a cart-based machine or a standard ultrasound machine, the process is less linear. So once you make the decision to perform an ultrasound, you have to go find the machine. And if it's not in the expected location, you get stuck in this loop of inefficiency, which I have outlined for you with the gray arrows. And similarly, once you have the machine and you bring it back to the bedside, a power source has to be identified. And again, there's this risk of getting stuck in another loop of inefficiency. All the outlets are taken or you can't reach it. You know, if you're an OB, you've definitely crawled on an L&D room floor to find a power outlet. It's part of residency training. But once you have that power supply established, then the device has to load, and then you can perform your ultrasound to make a clinical decision. So there are more steps required to perform bedside ultrasound when you rely on cart-based machines compared to a personal device-based probe. You also have a higher rate of redundant patient encounters is what we found, where a clinician would present to the bedside, complete their history and physical exam, and then return to the bedside for a second time for the sole purpose of performing ultrasound. So what we wanted to know was if this really matters, like these theoretical loops of inefficiency, and not just in terms of physician happiness, but clinically, do they matter? And so we quantified it. And you can see on this very busy slide that it does. And the big picture is that we found that clinical decision time took around 9 minutes when using a standard machine, compared to 2 minutes when you have access to a handheld ultrasound. And, you know, the reason why really is because in the graph, you can see the blue and gray in the graph depict pre and post scanning tasks. So that means time spent on non-clinical tasks like locating machines, cleaning them, finding power sources, all the tasks that we outlined in the process map that take up clinician time. But the thing that was really important to me was that if you take a look at the orange in the figure, the amount of time actually spent scanning was the same between groups. Statistically, there was no significant difference between the time spent scanning. And so the amount of time we actually saved is pretty significant. The labor and delivery unit where this study was performed, the census is around 7,000 deliveries per year. And every one of those patients underwent at least one ultrasound during their admission. So if you present to labor and delivery, we make sure that baby's head is down. So by my most conservative estimate, where each patient is truly only scanned once, we saved 51 hours of direct physician time per month by incorporating handheld ultrasound into our practice. And to be transparent and realistic, we scan patients probably 2 to 5 times throughout an entire labor and delivery course, between admission through delivery through postpartum care. And then on top of the labor and delivery service, most units also offer full OB triage services. So in this hospital setting, that was 400 visits per month. And so that was an additional 33 hours of physician time saved per month when using handheld devices. I'm just going to touch on briefly the comparison between the two images. If we could go to the next slide. And so this is an example of an abdominal circumference at 26 weeks. So one of them on the left is with, for just in layman's terms, a very fancy ultrasound machine. And then on the right, you can see the same fetus with the same, and at the same gestational age. And you can see all the same landmarks that you need. And so, you know, I also did do a validation study, but this is just an example so you can see for yourselves what it looks like on the two machines. And this is my baby, actually. She's born now, but you know, anyways, her abdomen was appropriate for gestational age, and that was confirmed with both a pocket probe and a standard machine. So that's just a little bit about the pocket study and the way we truly quantified the difference that it makes. And then just to kind of highlight other things, you do a lot of things with these devices in the obstetric setting. Here's an example of confirming that you have a 3-vessel cord. And so again, on the left, you have the fanciest machine, and on the right, you have the teeny tiny machine. And you can see that regardless of which probe you're using, you can confirm a 3-vessel cord. And I have countless examples of those, but those are the two I included to share today. And we've had a really good experience just integrating this into practice, but we wanted to do this study before we integrated it because we wanted to know, you know, it's a big change to our day-to-day workflow. Is it worth it? And the answer was yes.
Now, there always seems a little bit of noise about whether a cart versus a handheld is being used. Was there anything noise in terms of patient perception, whether they had someone come into the room with the cart with the handheld, in terms of what their experience was or what their expectation was? Was anything of that shake out?
Patients really like the handheld devices. It's, you know, it's a cool party trick, right? You know, they get to see their baby on a cell phone screen, and I feel like it's very positive. That being said, I practice in a very high resource setting. So, you know, my patients have plenty of standard ultrasounds in there during their care. So they're excited to just see a new modality, has been my experience.
And I guess to follow up on that, in all of y'all's experience, do you find that you mentioned like the quick head check? Do you find that like folks are wheeling over big machines for things like quick head or heart checks that could be so much more easily done with just the one pocket probe? So that's been my experience, and I just am wondering how everybody feels about that.
I would say definitely. So recently, and we have 2 clinics, 2 of our MFM clinics, and we have butterfly probes in one of them, and our other one are kind of our cart-based that we just use in clinic, you know, just to determine fetal presentation, wasn't working. And so that day we had to send every patient into our ultrasound unit where they're having anatomy scans, and we didn't have a butterfly. And I was like, oh, I wish we had a butterfly, because just the time of working patients into the flow of our ultrasound unit rather than having, you know, a handheld, it was really changed everything. And so we now have our butterfly there as well as our new cart based.
Yeah, the complement. And Carrie, in your practice in the community, do you find that having like a 3rd trimester scan just to quick make sure everybody is not having a high risk condition, or the baby hasn't changed position and is breech, or like how do you think about kind of late trimester or peri-labor scanning?
Yep, all of the above. I mean, if we see a client for a second time, I'll tell you the first thing that they say is, can we see baby? And that's one of the things when we get into the 3rd trimester, we're like, okay, what position is this baby in? You know, let's look. And that's exactly what we do. We see, make sure everything still looks appropriate, find the fetal position, make sure is baby head down, is baby breech, what are we looking at? Especially if they're a doula client of ours, right? Doulas are labor and delivery coaches. So knowledge is power, and just being able to give moms as much knowledge as we can is one of the most powerful things we can do.
Absolutely. Well, with that, I wanted to go round robin, and if you think about your ideal, you're like in the best of all possible worlds, the future of obstetric point of care technology, and you could combine ultrasound with anything, or like, what would be your ideal thing to have in your pocket, your ideal device to know all the things you wanted to know about your patient, and what would it do and how would it be?
My-
Oh, go, Dr.
Sorry,
EK.
sorry.
You and I, man. Go for
Same
it.
wavelength, same wavelength. I think the ideal situation would be to be able to, number one, decrease the activation energy for clinicians to actually use POCUS, because most times it's just getting people to use it, and the reason why they may not be able to use it is because they are not confident in their skills, or they don't have the training. So if there was a way for them to know that I can grab this machine and I can, somehow have some help with image acquisition, have help with image interpretation, and then call someone or have someone who can let me know how I can clinically integrate this into my care, I think that will decrease the activation energy. And I think that goes into like automation and then teleultrasound and then AI. So that would be ideal for me and for my practice.
My answer is not as exciting as AI incorporation, but I mentioned before we started, so a lot of my research is in EMR work and informatics. And so for me, the one thing I would love is if my butterfly could talk to my electronic health record easily. That would bring a lot of joy. And I think more use, making it very easy to document findings and just really streamline that process that's on my wish list for sure.
Oh, Cecilia, the future is here. We have to get you in touch with our solutions architects, because that can happen. The cloud-based aspect of it is different than it was 10 years ago, right? Now, handheld ultrasound can connect, right? And you can seamlessly upload images and have worksheets, and it can kind of directly be linked to billing and coding. One of the things that we found in our kind of early connections to the OB-GYN community is that a lot of people are doing POCUS in their practice and hardly anyone's billing for them. And there's a lot of low-hanging fruit for quick fluid checks, IUD assistance for difficult placements that, could be done with ultrasound and billed for as a limited point of care obstetric ultrasound, and it's like left on the table. But I think one of the barriers to that is getting the images uploaded. And so happily with Butterfly Week, we can help that. But yeah. Carrie,
Well,
what about
there's
Yeah,
also
no,
been an
you guys have all touched on everything that if I wanted in one perfect little device, that would be it. And just being able to do all the things at the bedside with, accessibility to having that ultrasound, especially when you collaborate with other providers, if they don't have to go in to have a biophysical profile done, the AFIs do it at the bedside, gestation, all of that. And I will say that Healthy Mothers, Healthy Babies is successfully billing for these ultrasounds that we do. It's one of the easiest things we do, and it is definitely not left on the table.
That's awesome. We should be in touch and delve into that, because I think that's a lot of there's a lot of teaching that could be done around that, just awareness for other providers, right? Because when we think about sustainability, we often think about like environmental sustainability or the product itself, the physical sustainability of something, but the financial sustainability is really kind of what makes the whole process tick. And so if you can bill for exams when your probe costs, under $3,000, and you bill for a bunch of exams in a week, you're going to very quickly make it a cost neutral and then revenue generating thing for your practice, which I think is really important when thinking about putting handhelds in limited resource settings or in obstetric deserts in the US, and making it, at least cost neutral, but certainly, slightly revenue generating is really kind of exciting. Well, I wanted to shift gears to talk about AI. So we've mentioned AI, and Dr. Stringer, do you want to talk about kind of where your team is taking this and why?
Sure. So and then I'll show a video after I just kind of give the background. So this has really been a labor of love for the past 5 years. I think that one of the mottos of our team has been democratization of ultrasound. And so for the past 5 years, with funding from the Gates Foundation, the team has been working on AI-assisted ultrasound to determine fetal gestational age. And so there was a large study just to develop the AI model. And then we essentially have just completed what I would consider almost like a phase 3 study, where it was a validation study comparing AI-generated gestational age to expert obtained biometry. And the AI gestational age was as good as, if not better than, expert obtained biometry. So that GA, gestational age, is the first, I think that we've tackled. And we're developing different models now, such as presentation, singleton twins, fluid. And so I'm going to show you a video now about our new app that has multiple features. And I'll just talk. So this is called the Family app, and we have a pregnant person here, and this is a research assistant. She is not a trained sonographer. She's entering the patient name and birthday, and then she's going to scan, and it's going to go a little faster. So just bear with me during this little boring component of the video. So she's now selecting, so she selected the AI tool app. On the other side of the screen was the live scanning mode on the butterfly. The app adjusts the depth depending on the fundal height of the patient. And so she is now measuring the fundal height from the pubic symphysis to the top of the uterus, for those non-obstetricians who are watching this. And so based on the fundal height, the depth is automatically adjusted on the probe, as well as it guides the user through the number of sweeps. So there's an additional sweep if the participant is further along in gestation. So she's entering the fundal height. Now this is showing the guided blind sweeps in the app. So the first is a midline sweep. And I was recently training Zambian midwives on how to do this, and they could learn really quickly, like in half a day. So there are 5 sweeps, blind sweeps. Now there are transverse sweeps. Each one takes 10 seconds.
So the whole process is 2 or 3 minutes of blind.
Whole process is 2 or 3 minutes. And then if we can pause it right there. So this is the output from the app. And so this patient is 35 weeks gestation. It gives her due date. It actually tells you the estimated fetal weight, the amniotic fluid, the deepest vertical pocket, and then the presentation, and then if it's a singleton or a twin. So it kind of gives me chill bumps to think about the capacity of this and where we can go with the future and how this can really change care in many settings. And as you were discussing earlier, Suchita, I think that this has a lot of utility in LMICs because we, for the obstetricians on this webinar, we know how important determination of due date is. It's really one of the most important. It's the first thing we do when we see a patient is establish their gestational age and their due date, because that helps guide many things that we do in the rest of the pregnancy. It tells us if the patient is going to deliver, it tells us if we have a preterm person who's coming in and whether we need to administer medications, or it tells us if someone's post dates. And so that EDD is really important. I think this is also really important out in the United States, where we have a lot of clinics where patients cannot get ultrasounds, right? And so I think there's a lot of utility around the world for this. And yeah, that's all I have to say.
I agree. And so to zoom out a little bit, the family app was created. Actually, UNC was our first Butterfly Garden partner. But back in the fall, Butterfly opened up our software development kit for outside AI developers wishing to interoperate their app and their AI algorithms with Butterfly ultrasound images. And so the work with UNC in partnership with Butterfly has been ongoing for quite some time, especially around this gestational age piece that's really hard to physically sit there and teach someone how to do, and just kind of harder for novice learners to novice users of ultrasound to learn. But then it became clear that this kind of super tool with the suite of information that you might want could also be obtained from a lot of that in research that was being performed, and putting it into an outside app that interoperates with an ultrasound probes software just makes it totally seamless and be able to run quite well. So in just a few short weeks of working with the SDK, this prototype was created and is running quite well and already in research phases. And so we have a number of other Butterfly Garden partners that are building AI around ultrasound for a variety of conditions that might affect mom that don't have to do with the pregnancy. But one of the really mind-blowing things when Dr. Stringer's team and Dr. Jeff Stringer, Elizabeth's husband, had explained this to me. So I was thinking like, oh, so the AI is measuring the baby's head like I would normally put my calipers around the head. And he was like, no, the AI is looking at things that we don't even look at, which is just like mind-boggling to me. That the AI can look at different features of thousands of scans and create an accurate, highly accurate algorithm of things that we couldn't measure with our eyes as clinicians. And to think about having that information at every point of care where a patient that is pregnant shows up, has their blood pressure taken, maybe their weight, and then, you know, a medical assistant could do this scan and give all of this information to the clinician, and they could ultrasound and show the picture of the baby to the mom and do all the things, but they would have all of that really key information right up front. Is I think so exciting for the future of maternal care.
And I guess there are a couple, I was going to mention one other application even, or where I see other applications for AI. And I was taking care of a patient, and the partner was an EMS technician. And he was telling me that they do fast scans in the field, but they couldn't interpret them because they're in the ambulance. And I was thinking to myself, great application for AI with determining fast scans. If you have someone in the field who can't interpret it, then, you know, we can get that into the field. I guess there was a question about whether the family app is currently available. So it is currently available in research settings, and so we want people to use it. I mean, we want to get it out there. We're working with physicians in Rwanda who've just submitted an IRB to try to validate in their setting. South Africa, the Congo. So, Suchita, if people are interested, they can reach out to me, and I would be happy to. We'd be happy to talk to them.
Yes, absolutely. And we can, we have a number of research partners that UNC and your team is already working with, who are procuring Butterfly through the Global Health Program for use outside of the US. And then, getting in touch with the UNC team about how to use the family app in research. And so it's on the horizon. Calling all AI app developers and researchers out there. This is a really exciting time to be in medicine, because these barriers of training, we've slowly been breaking down with the AI guiding for helping training and labeling, and our Scan Lab app, and the teleguidance where, the provider or the teacher doesn't have to be at the bedside. They can be in a different part of the world. But really this is the next frontier for the future for ultrasound.
And I'd like to add, Suchita, that if we could even go one step further and say, why does a teacher have to be across the world? Why can't the teacher be the AI, right? Why can't the AI be giving you immediate feedback on, is this as Dr. Eke was saying earlier, right? With image acquisition or interpretation, or, with training midwives in Zambia, they have the ultrasound machine, and okay, we have one. I think we could just do all AI, or we could, when they're identifying a head, the AI could help them say, this is the fetal head, right? So they get more confident in their diagnostic skills. And so I think there's so many applications for this. There's full AI, but there's also assisted learning, which is relevant for our trainees in the United States, and also trainees around the world.
Yeah, I agree completely. And when you think about AI for ultrasound and how it might interact or interoperate with, the AI that's being developed around lung sounds for stethoscopes, right? Or large language models listening to patients speak and pulling out themes, or helping to direct, the severity of their illness, with dials of I think about like turning dials in my brain is how I think about it, but like, oh, where are we in the world, right? Are we in a high income tertiary care center? Are we in a kind of lower resource context where we don't have all the things? And then I think the teaching and training kind of can jump to the next level of how do you integrate all of this knowledge and make decisions. But that's probably going to become AI guided as well. So lots in the future.
One of the things about AI is ultimately it's how to reinforce someone picking up the probe and using it, right? That's as everyone works on trying to educate it, it's not only get confident from the eye, but get confident that learning, it always takes, even with AI, it still takes manual effort and manual intention, and the ability to be open-minded to learn something new. We had a question here about resources for midwives in the US that I thought, Carrie, if there's something you can either speak to or we can connect later on, but a question about running. What resources are there, speaking of trying to become confident and make better clinical decisions, if there's some resources available for other midwives in the country to mimic what you're doing, essentially?
I think definitely we could probably put some resources together,
Great.
and have them sent out later. I mean, I can't think of anything right off the top of my head, except, being able to connect with you folks and having the device and training and using it. That's the biggest help. And that's initially the step that we took to begin using it. You don't need a special certification. You already have the credentials to do what you need to do to be able to utilize it. The next step is being able to purchase it and then understanding how to use it yourself.
Absolutely. And there's a series of quick teaching videos for, how to measure fetal heart rate, or how to do biparietal diameter, how to tell baby's presentation, that are embedded in the OB presets in the Butterfly app. But we also have a list of open access resources, you know, a kind of a mix of butterfly and non-butterfly teaching and training materials that we're happy to send out to this listserv after for all that registered. And so I believe we're at time. If there's any last burning questions, feel free to pop them in. But otherwise, I just wanted to thank all of you for taking the time to speak with our webinar participants today, and to thank all of our panelists for their time and their expertise and sharing all of their knowledge and their passion for this tool in their practice. So thank you from the bottom of our hearts. And it looks like there's, are there any other recs for an L&D nurse wanting to get better trained to teach others? We will definitely send out some training resources because it seems like people are fired up now to learn. Fantastic. Thank you all so much, and have a great rest of your days.
Thank you.
Yeah, thank you all.
Thanks, everyone.
Thank you all.
Thank
Nice to meet
you.
you.
Have a good night.
Night.